Thanks, Alex. Thanks, Dr. Khan. I feel like, again, there's much more we could talk about here, but we're going to move on now from supporting the mind to supporting the body. And nutrition is vital to well-being, and Duchenne UK has funded a project looking into this area. And I'm delighted to say we're joined by two people who've been carrying out that research. Dr. Jarod Wong, who's a clinical lecturer and consultant paediatric endocrinologist at the Royal Hospital in Glasgow, and Dr. Laurie Cave, who's the lead clinical research dietitian of the DMD Care UK Diet and Nutrition Project.
So here's where I start. A year after starting steroids, at an average age of 6, boys 6 years of age, 30% are carrying excess weight, so with body mass index in the overweight and obese category. 3 years after starting steroids, average age of 8, fast forward a few years down the line, 60%, so count 10 of you in a row, 6 will be overweight, obese, or some are already significantly obese. I don't need to tell those of you who are parents, you see that. These are data from a group of boys in Glasgow, all on daily steroids. Some are on flazacort and some are on prednisolone. And it mirrors quite similar data published recently from Melbourne, which shows that at an average age of 11, 50% are overweight, which means 1 out of 2. Obesity is a chronic disease, and I think we need to start to reframe that in Duchenne and see what we can actually do better for these boys. And this is where we start with. My name is Jarod Wong. I'm a pediatric endocrinologist in Glasgow. I'm joined by Laurie Cave, Dr. Laurie Cave, who's a clinical research dietitian, and thanks to Duchenne UK joining Jack and Alex's wish, we hope to make some changes which will improve outcome for these boys. I don't need to tell you the impact of obesity, but specifically in Duchenne, we now have data to show that obesity is associated with increased blood pressure and also some of the Duchenne-related heart outcomes that Anna and Michaela talked about earlier. We also know that there can be impact on respiratory function, in particular this matter of sleep apnea or blockages of the windpipe. So a decade or so ago, we're seeing boys started on respiratory ventilatory support because of weak respiratory muscles, but we're now increasingly seeing boys who are started on respiratory ventilatory support because of the blockages of these windpipes and because of obesity. And that is something that we need to target. We also know that obesity, and including in Duchenne, can be associated with conditions like type 2 diabetes or abnormal handling of carbohydrate or sugary food. And there is some, but not all studies have shown that obesity might be associated with physical function, i.e. muscle function. Some have not shown that link. And one recent study that shows that obesity may be related to the risk of fractures in boys with Duchenne. And for sure, having heard what Rory talked about in terms of mental health, self-esteem, obesity is something that grossly, significantly impacts on boys with Duchenne. In a recent survey that we did, asking boys with Duchenne, which are the 3 steroid side effects that actually matters or bothers them the most, guess what? Short stature, obesity, and Cushingoid features. Not hypertension, not type 2 diabetes. That's what matters to them. And I think it's because of that we do need to do something. So, why do we gain weight? Why do I gain weight? Simplistically saying, it's an in and out matter. You all know that. So it's an energy balance matter where if energy intake exceeds energy expenditure, i.e. the energy that we need to survive day to day just by sitting or sleeping, we gain weight. But things are never so simple in Duchenne. And because there are a few different factors. Muscle mass needs food. It needs fuel. And we do know that people who have higher muscle mass have higher energy expenditure, and of course, boys with Duchenne have lower muscle mass, and that certainly is an issue over time. Add to that, there is limited physical activity, and of course, we've got a whole range of other things which can contribute to weight gain, like sleep disturbances and poor mental health, but particularly steroids. It does increase appetite and also lead to differences in the energy expenditure. So what do we know about the impact of steroids on weight gain? So all steroids is associated with weight gain as a group from the research that we now know. But some might actually have a greater impact on weight gain. So results from what Michaela already explained earlier, or showed earlier, is that 10 days on, 10 days off prednisolone and daily prednisolone is associated with similar degree of weight gain. Daily deflazacort as a group seems to be associated with slightly less weight gain, but weight gain still happens, and there can be variations between patients as well. The new steroid that we've mentioned, and Michaela has mentioned, called vamorolone, which is not available to be used clinically yet, does also seem to be associated with weight gain, similar to prednisolone, which is studied in the clinical trials. So we do know steroids play an impact. But let's look at some information on energy requirements in boys with Duchenne, and this is thanks to Dr. Zoe Davison and Dr. Natasha Billish from Melbourne. These are some unpublished data. And this really shows that in ambulant boys with Duchenne, at the average age of about 9 years, calories burned at rest, so i.e. calories that you can consume just to survive from day to day, is approximately 1,200 calories. And these boys are still participating in physical activity, and they burn 600 calories, which means that total calories consumed for a young boy with Duchenne who's still ambulant is approximately 1,800 calories. We have very limited information on measured energy needs in boys with Duchenne when they're non-ambulant, something that we're hoping to do in this project with a bit of difficulty, but with your help. Some of the estimated values from Zoe's study shows that certainly calories burned at rest will be much lower than 1,200 calories, but because physical activity is so limited, it's estimated to only be 100 to 400 calories burned per day, meaning total calories consumed in a non-ambulant boy is about 1,300 to 1,600 calories, and I don't have to tell you what kind of food you consume in a meal or 2 meals that will take up your daily allowances. Now, how does it compare with healthy boys? And so we had some data from healthy controls. And in the ambulant boys, we saw that as a group, these boys with Duchenne could consume 1,800 calories, but in boys without Duchenne, about 1,900 calories, so probably roughly similar, but maybe a little bit lower in boys with Duchenne. But you can see the big difference in the non-ambulant boys. Now, bearing in mind these are unpublished data, and not saying that a non-ambulant boy should only eat 1,300 calories, because Laurie will say that this might actually not be sufficient for overall health. So that's just to be clear here. I'm just giving you an idea of the issues of calories in and calories out. But Zoe and Natasha have also done brilliantly some studies looking at what boys with Duchenne are eating. Young non-ambulant boys are already over-consuming in terms of total calories by as high as 400 calories per day, even though they at that time are young and they've got a healthy weight. So the issues are early, and any nutritional education and intervention needs to be targeted early, in our opinion. These boys are also not necessarily consuming the sufficient serves, and serves is a very Australian concept. It's an Australian study of grains, of poultry and fish and protein, and also calcium. So dietary information, education is clearly important. And what about what we're doing in the UK in the clinic to try to monitor and inquire that? Pretty badly, actually. There's a survey thanks to Sejal, who's worked really hard on the DMD Care UK family survey. And I really just want to put that up for you to see that really regularly reviewed in terms of inquired of nutrition and food, very small amount, a little bit better than psychosocial maybe, and fluid intake, I suppose water and maybe also alcohol is never really just inquired, but of importance in this population of boys. So, families do recognize the importance of nutrition and of good food, but there's complexity of lots of other issues. One of the things to also mention is that professionals, particularly clinicians like myself and not necessarily dietitians, just don't feel comfortable in engaging in conversations about food because that's not our background and there's very limited dietetic support in the NHS for boys with Duchenne. There might be differences in priorities between clinicians and the families at some point, and families sometimes actually just want to have a normal life. And that just needs to be borne in mind, whatever we do. But the key to say is that weight gain in DMD is not a weakness. It's never a weakness, and it's not a failure of the family. And I think a lot of us need to hear that. Obesity is a chronic disease. It's not a weakness. It's not a failure. So this is where I pass on to Laurie. I've given you lots of negative and depressing news. It's Laurie to actually bring up all the nice things that we hope to achieve.
Try anyway. So hello. So we've just started our nutrition working group, and we convened just 2 weeks ago. So we're talking we've just started, but we've got a fantastic group together. So there's myself and Jarod chairing, and then we've got Vasiliki supporting us, who's also in the Glasgow team. And then we've got sort of subgroups of other clinicians. So as clinical dietitians, neuromuscular clinicians, and then endocrinologists. We've also got our expert advisors in Australia who are clinical and research dietitians, got a lot of experience in Duchenne. And we've also got our patient representatives as well. And really what we're trying to do is to, there's some guidance there already from the International Standards of Care, but when you look at that, that's saying that really a dietitian should be seen at every clinic visit, so every 6 months, and I think we could count on one hand the number of centres that actually happens at. And so we need to look at what we've got there in terms of the international standards and see what's applicable in the UK and in the NHS. NHS is really under pressure, and really what's possible to deliver. But alongside that, something major that we can do is really to develop guidelines, so national, nutritional guidelines, so specific for nutrition in Duchenne. And really start looking at models of care. So, if there's not a dietitian available, or if we're working towards a dietitian being available as part of the team, when you go to clinic, then what does that look like? So starting to try and move the dial, and also looking at how we assess and excess, if children are gaining excess weight, and then how we manage that. So along with that comes a big gap in terms of patient and clinician education and information, so specifically around nutrition in Duchenne. And then we need research. There's so little done to help us to work all this out, really. So we'll go on and say a little bit more about those now. So we've got kind of a roadmap, I guess, in terms of where we're at right now and where we're going. So I say we're just starting, but really, as I said, we've got those different groups of clinicians within the working group. So that means that we can go away and do some really detailed work. So as dietitians, we can come together, do some really detailed work. Neuromuscular clinicians, really detailed work, and bring that together and pool all of that so that we're really, really moving forward with things. A big thing what a big thing we need to do to begin with is a look at what's there already, so what evidence we do have, and really we think there's very little, but we need to look at that really, really thoroughly. We need to look at what recommendations are there already, so that's looking at the international standards of care, which have got a North American focus, and saying actually what's really applicable in the UK context. And then really gauging through surveys, so with parents, so patients and families as much as we can, and clinicians, to really find out what's going on the ground, really where those gaps are, so that we can really start addressing those within the guidelines. We think there's very little evidence there, as I say, so it's going to really be probably more of a case of, this is what we kind of know, this is what we do, this is kind of what we know might work, but we're not sure that's specific for Duchenne. So a lot of that's going to be through bringing experts together, which includes you, as to what seems to be working, what's not working, and really just trying to come up with some best practice, really, so that we got a starting point to move from. And then with the hope in time that as we get more evidence, as we get findings from our research, then we can add that in and really move things forward. So I mentioned about developing information and resources. So really, at the moment, in terms of developing this for patients and families, we're looking at resources that are already out there that might be used in other areas, but that maybe we can borrow, tweak, whatever, for Duchenne. There's lots of really amazing stuff out there. So rather than reinvent the wheel, we're really thoroughly looking at those and how useful they could be to us. We're then wanting to develop a series of video shorts. And these are just our current ideas, so we're really up for hearing any ideas, really. But really to have really clear information, but that's tiny, so like kind of bite size, on topics that keep coming up. But that at the moment there's a lot of fuzz out there on the internet and things. It's really hard to know. But so for example, the real basics, real essentials of nutrition, but in the context of Duchenne. There's lots around protein intake, fluid these are just examples, but just to give you an idea of the sorts of topics. We're looking to get going on our series of those kind of April-May time. Then in terms of other resources, so there's just an example, but things like recipes, this comes up a lot in terms of gap, but really looking at healthy versions of meals and snacks that boys are going to be eating anyway, and doing that in the context of things that are possible to cook in a time frame, because time is, your time is taken up hugely with all the other demands, and that are cost effective as well. So, but also, trying to make this really practical and trying to get the boys involved as much as we can as well. The other thing then is resources for healthcare professionals. So, as I said, we've got the amount of dietitians that can input into clinic currently is very, very limited. So really keen to develop resources that other clinicians within the team can be using within clinics. So simple things so that they've got something to turn to and maybe feel confident then to start having some of those conversations, or to start making some simple assessments in lieu of having a dietitian there to do it. This is kind of while we don't have that, I guess. The other thing that we'd like to get going on is having some regular group sessions. So we're thinking these would be online so that everyone can join, but having them as themed sessions. So we'd like to suggest topics for these groups in advance, and then so that we can invite your suggestions and your questions, so that we can prioritize what the content is. So we're addressing your priorities, your questions as much as we possibly can, but really looking to make those group sessions really practical, really visual, as interactive and as fun as possible so we've got patients really taking part in that as well, and really provide an opportunity for peer support and peer-to-peer learning. So there'll be stuff that you're each doing which works for you, and actually sharing that, because that might work for someone else as well. So we got lots of information there that we could be sharing. That would be brilliant. Yep, I'll hand back to Jarod, I think. Sorry.
The last bit is research as part of this project. And as part of this project, there will be 3 pieces of research that we'll be doing. First is basically looking at timing of weight gain or trajectory of weight gain following starting steroids, and also the smaller group following loss of ambulation. Second is a more detailed study looking at energy needs in ambulant and also non-ambulant boys with Duchenne, so that they can guide our nutritional guidance in the future. And thirdly, some qualitative work which includes surveys, but focus groups and interviews to see how we can actually develop nutritional care in the UK. The study involves some data from the North Star database, but also retrospective data looking at timing of weight gain using DEXA, but also North Star database, and this is already started. We are also going to be doing some of the energy balances study that I mentioned earlier that Zoe Davidson has done, but also addressing the measured energy balances in non-ambulant boys with Duchenne. It will be based in Glasgow, but we are opening recruitment to all boys all over the UK, and there will be information on your boys' nutritional, your food diary that we will feed back for you to bring back to your clinician. We will be doing interviews with families, young boys, boys and adolescents with Duchenne as well, specifically asking about model of care and seeing if we can adapt a nutritional program designed for boys with Duchenne muscular dystrophy in Australia to be adapted in the UK. And we really, really want your input, and that's crucial. And these are the people. We've got Laurie, we've got Vasiliki, and Aljazi is a PhD student who unfortunately is not well and not being able to be here. Our external expert advisors, Zoe and Natasha, great friends and colleagues in human nutrition, Dr. Darlene Malkova, Professor Konstantinos Gersimidis, a great friend Nicola Crabtree in Birmingham, and also Professor Lucy Bray, who some of you might have met from a much more recent piece of work that we've done, asking families and also boys with Duchenne about their management of osteoporosis and if treatment with bisphosphonate can be started prior to first fracture. Thanks to about 15 to 18 families that we've spoken to, including boys with Duchenne, we are hoping to get close to 30. So if you're interested and able to participate, please get in touch with Lucy. This is some information, and there are some leaflets out there. I'm going to end as where Emily started, in a dark room. It sounded pretty depressing in my talk, but we will move away from the dark room. You could try to turn on the light, but when you can't turn on the light, you could light a candle, and that makes it a little bit brighter. But actually, one person can't achieve very much, and I think it's been great to collaborate with Duchenne UK on this nutrition project. It's been great having Laurie on my side. I can't do nutrition. 2 candles are brighter than one, and 2 people have actually achieved a lot. Okay? But we want more than 2 candles. We want every single one to you, because this is your nutrition project. We want your ideas today at the start. At the DMD Care UK table, please drop any suggestions you've got. Nothing's too silly. Feedback to us all throughout the project. Give us ideas. Tell me if my idea is shit. I like to hear about that, because we will get some things wrong, but we only know if you tell us, okay? Participate in the surveys, participate in the focus group, because this is your project, and because 1's great, 2 fantastic, but lots and lots of candles make it bright. Thank you very much.
So lovely to end on that vision of hope, lots of candles together in a room. I feel like we can participate in that. Thank you very much, Dr. Wong and Dr. Cave. Clearly much to do in this area, but with your input, we can really make progress.